Spermatogenesis is the process of human sperm production, which occurs in the seminiferous tubules of the testes. This process begins at puberty and continues throughout adulthood. The spermatogonia diploid cell, as shown here, divides mitotically to produce more and more spermatogonia cells. After the male reaches puberty, however, the anterior pituitary gland releases a hormone known as the follicle-stimulating hormone, which only allows the spermatogonium to produce one spermatogonium and one primary spermatocyte with each mitotic division. Here you see the primary spermatocyte, the diploid cell. It's about to undergo the growth phase, and then it will become the primary spermatocyte, except larger. So the primary spermatocyte, the diploid cell, as we mentioned, will undergo meiosis I. However, it must be noted that the DNA replicated before the division occurred. This process will then form two secondary spermatocytes, which are haploid cells. Each of these secondary spermatocytes will undergo meiosis II, in which the DNA will not be replicated before division. This will produce four spermatids. These are haploid cells, but they are not functional gametes. Each of the four spermatids will then undergo a process known as spermiogenesis, in which the extraneous cytoplasm of the cells are stripped away, converting each spermatid into four functional sperm, with a haploid number of cells. Once enough sperm are produced, Sertoli cells will release inhibin, which inhibits FSH, the follicle-stimulating hormone, which will decrease the rate of spermatogenesis. Oogenesis is the process of female gamete formation, which occurs in the ovary, very similar to spermatogenesis occurring in the testes. Oogenesis begins with a diploid stem cell known as the oogonium, as shown here. The oogonium undergoes a series of mitotic events during fetal development until there is 2 million or more oogonia. Then they become encapsulated by a primordial follicle in the ovary. After birth, most of a female's oogonia will become larger and turned into a primary oocyte, also a diploid cell. After puberty, the follicle-stimulating hormone will stimulate the follicles to undergo maturation about every 28 days. This change causes the follicle to grow and become the primary follicle. This follicle produces estrogens. The primary oocyte seen here will undergo meiosis I, completed by the primary oocyte each month in response to the luteinizing hormone surge. The primary oocyte will produce two haploid daughter cells, one small first polar body, which will then undergo maturation to form two more polar bodies, and also one secondary oocyte. The secondary oocyte is still arrested in metaphase II. The luteinizing hormone released by the anterior pituitary gland will stimulate ovulation. The secondary oocyte will embark on its path to the uterus via the fallopian tube. If penetrated by a sperm, as shown here, the secondary oocyte will undergo meiosis II to produce one large haploid ovum and another, shown here, second polar body. Once meiosis II reaches completion, the male and female pronuclei combine to form the diploid zygote cell. If the sperm had not penetrated the secondary oocyte, it would have disintegrated without producing a female gamete.
Hi, I'm Dr. Endaya.
Hello, I'm Angela.
How are you?
Good.
And this is your first time pregnancy?
Yes, it is.
How is it going so far?
It's going great.
It's going good? So typically with first time pregnancies, this is something I like to go over. This is pretty much describing early embryonic development. So this begins with the woman's menstrual cycle, and this prepares the woman's body for fertilization. So it all starts right here in the ovary. The ovary releases an egg, and the egg travels through the fimbriae all the way through the fallopian tube in the infundibulum. Here is where fertilization begins. This is where the sperm and the egg meet, and this is called a zygote. This is typically where traits and genes are formed, such as eye color, hair color, a Y chromosome for a boy, X chromosome for a girl. Then as the zygote begins to divide, this is what we like to call cleavage. And then it becomes smaller and smaller, the cells do, and this is what we call blastomeres. Then it continues dividing and it becomes a morula. This is usually at the 32 cell stage. Typically, this whole process lasts about 3 to 4 days within the fallopian tube. It then begins to hollow out and becomes an early blastocyte. And then, as you can see here, the final product of cleavage is the implanting blastocyte. And this typically implants or should implant in the uterine wall of the endometrium. Then when it implants there, usually you'll have symptoms of spotting or cramps. Usually only last about 48 hours. And then for the rest of the time, the rest of your 9 months, that's where the egg will mature and continue to grow.
Okay. Complications that I should be aware of?
Yeah, so a complication that I like to go over with new mothers is typically when an egg implants in the fallopian tube, or it can be in the cervix or any other lower abdominal area. Because typically for a normal pregnancy, we like to see the egg implanting in the uterus. So when it implants within the fallopian tube, that's what we like to call an ectopic pregnancy or a tubal pregnancy. And this is actually a medical emergency. So I do like to tell new mothers about this because if left untreated, it could be fatal to not only the fetus or the egg, but also have life-threatening measures to the mother also.
Okay. What are some symptoms?
Some symptoms are nausea, heavy or severe bleeding, and that's usually because the fallopian tube is ruptured. So that's why you have internal severe bleeding. Also vomiting, sharp cramps, dizziness, sharp abdominal pains, anything out of the ordinary that you would normally not expect during a regular pregnancy.
What are some of the causes for the ectopic pregnancies?
Number one cause is a ruptured fallopian tube. Another one is pelvic inflammatory disease, and that's usually goes hand in hand with STDs such as gonorrhea, chlamydia, that sort of thing. Also birth control such as IUD use, and also in vitro fertilization. And especially if you've had a history of this type of pregnancy, that also plays a part.
Right. How do you treat it? Or test for it?
Testing, typically if a pregnant mother comes in with any type of symptoms out of the regular, like I just discussed with you, we typically go ahead and do a pregnancy test, we do an ultrasound, and we also do a pelvic exam.
Okay. And for the treatment?
There's no way to save the pregnancy, so what we would go ahead and do is we would do medical emergency surgery to pretty much stop the bleeding. This could be removal of the actual fallopian tube or ovary if needed. If the fallopian tube isn't ruptured and we catch this type of pregnancy early on, we can do a laparoscopic surgery, and usually that preserves the fallopian tube or the ovary and pretty much just removes the egg.
Okay. Thank you. That was very informative.
Yeah, and also another thing to be aware is after this type of pregnancy, and after, if you have the surgery and everything, we'll keep you up to date with any type of blood tests to make sure there's no HCG still present, because that is the hormone that is produced while you're pregnant. So we want to make sure that there's no pregnancy still going on and everything was removed safely. And the chances of you getting pregnant after are still good as long as you have one good working fallopian tube.
Good to know.
Yeah. So I hope this is very informative to you, and if you have any type of complications, feel free to contact me.
Thank you.
Nice to meet you.
You too.